Good afternoon, and welcome to this workshop that is entitled Best Abstracts in Endocrinology. Here is Dr. Sanazan, myself. I am Alberto Battezzati, and we will be chairing this interesting session that is focused on the impact of new modulator therapy on endocrine aspects, which ranges from glucose metabolism, body composition, contraception, and current standardization problems in the clinical practice. We have three educational objectives. The first one will be to evaluate the impact of new modulator therapy on glycemic control and nutritional status. We have three presentations regarding this educational objective.
So our second educational objective will actually focus on reviewing the clinical practice gaps that are related to dysglycemia as well as its management. And then our final objective for this session will look into contraceptive use as well as pregnancy history in women with CF.
Very good. So again, welcome, and let's start with the presentation. The first presentation is delivered by Dr. Michael Stalvey, that is a clinical and translational scientist that is associate professor at the University of Alabama at Birmingham, and its presentation is entitled PROMISE, Glucose Excursion and Insulin Secretion Following 12 to 18 months of highly effective modulator therapy. Dr. Stalvey.
Hi, good afternoon. It's as someone who has moderated the last session of the CF meeting before, it's fun to be back up here. And it's also fun to know the majority of the people in the room. So if you throw eggs and tomatoes at me, I'm going to know who you are. And from a standpoint of questions, I'm sorry if I seem to rush out, but I have another talk in about 45 minutes at a different room. So that's where I'm going. But it's an honor, it's a pleasure to present this to you today on behalf of myself, on behalf of my co-PI, Andy Kelly, for the endocrine sub-study of PROMISE, on the impact that we've seen so far over the first couple years of ETI therapy in adolescents and adults with CF. From a disclosure standpoint, I do have grant funding from the CF Foundation, as well as I sit on the medical advisory board for Vertex Pharmaceuticals. Since I'm the first talk, I get to talk a little bit about background. And CFRD continues to be the leading comorbidity of individuals with CF at close to 20% of all individuals or all ages. But it's smaller in the young people, but as high as 50% in the older individuals over 30. As you can see from the graphs, it is a progressive state of insulin deficiency that increases in incidence as age increases. Although the pathogenesis of CFRD remains unclear, and clinical observations, case series, and registry data, though, have reported improvements with CFTR modulator therapy, specifically ivacaftor, for individuals with the CFTR gating mutations from the standpoint of glucose tolerance, improved insulin secretion, and reduced diagnosis of CFRD. This was part of what inspired the endocrine sub-study of PROMISE, in which we basically designed it to evaluate the effect of ETI therapy in CF individuals with the more common delta 508 mutation. PROMISE, just to point it out, is a prospective observational study of ETI in individuals with CF aged 12 years or older with at least one Delta 508 mutation. A total of 489 participants were enrolled at 56 centers throughout the United States. The endocrine sub-study was performed at 10 sites throughout the country, in which we did a 3-hour oral glucose tolerance test. And during that glucose tolerance test, there were 10 samples obtained. And we looked at various things, which I'm going to go into in just a minute. We did enroll individuals that were on just basal insulin alone, but they were required to hold any kind of rapid-acting insulin. Individuals were then delineated as the glucose tolerance, as you see on the slide, as either normal, early intolerance, in which they had an elevated 60-minute glucose of greater than 155, but a normal at 2 hours, indeterminate glycemia, in which they were over 200 at some time during the glucose tolerance test, but yet the fasting in 2 hours were normal, impaired glucose tolerance, and then CF-related diabetes. We looked at baseline and 12 to 18 months. I say 12 to 18 months because of the issues with COVID. There was a time lapse and issues of getting those patients in and whatnot. But we did both the multiple analysis of various endpoints, looking at everything from changes in BMI to pulmonary function, et cetera. And we looked at glucose tolerance, hemoglobin A1C, oral glucose tolerance values, insulin sensitivity, and insulin area under the curve. This is just a basic table here telling us about the background patients that we enrolled. We had 67 patients that completed both baseline and 12 to 18 months glucose tolerance tests. It's roughly 50-50 from a standpoint of male to female, and the median age is 18. I'm not showing, but you can see from other papers, there was an improvement in everything from BMI Z-score, FEV1, et cetera. But what we found was an improvement in hemoglobin A1C, although modest, but still significant. A trend towards an increase in fasting C-peptide, and ultimately an improvement in fasting glucose, which I'm going to show in more detail in just a second. Here you can see the fasting glucose and hemoglobin A1C changes for not only those all-comers that for this study, but those that were on no insulin whatsoever. So when we eliminated those that were on any kind of insulin therapy, there was an even tighter distribution from the standpoint of that improvement. Now, when I break down the oral glucose tolerance testing throughout the 3-hour period, you can see here is the first mark at 30 minutes, and what we do is we're looking at incremental area under the curve. And what I want to draw attention to is the increase in insulin secretion and insulin area under the curve at the 30-minute period. And I'm going to show this in more graphic detail later on in just the talk. Here's going backwards. Here's the 2-hour mark, and what we're seeing now is the continued increase in insulin secretion and insulin to glucose secretion, as well as C-peptide secretion and C-peptide to glucose. This does not hold up at the 3-hour time period. And so this is maybe a reflection of what we see in the clinical diagnosis of CFRD. Now, from the standpoint of the overall picture in the glucose tolerance, we did see a time shift in the glucose tolerance and a peak glucose value that was earlier at the 12 to 18 month period, which could be a reflection of those changes in insulin secretion. Here you see the insulin secretory rates and the insulin secretory rate to glucose that I was just telling you about at both baseline and at 12 to 18 months, as well as the C-peptide and C-peptide to glucose at 120 minutes. Now, what I'm showing you now is the insulin secretion or insulin secretory rate of all comers that were involved in the study. And the green represents the baseline, and the red or the orange, how you see it, is representing at 12 to 18 months. And if you look closely, you can see kind of a shift towards an earlier secretion of insulin. And I'm going to break that down in just a second. This is individual patients. And this is where, a lot of times we talk about what are the clinical outcomes. And from a standpoint of where we're seeing the most impact has to do with those that are normal glucose tolerance or early glucose abnormalities or impaired glucose tolerance, where we're seeing a shift towards a more normal. You must remember that the typical thing is to have a first phase insulin release. And one of the things that we know is lost very early in CF patients, as well as CF-related diabetes. And what we're seeing here is kind of that shift back towards that early release of insulin that they're supposed to have. However, we weren't seeing it as much in those that have progressed on towards a diabetic state. Now, one of the things that matters most to all of us is what is the clinical outcomes. And this is an interesting finding. What we saw over these two-year periods is a lot of fluctuation and changes, especially in that early status that I was talking about. So those individuals that are mild to moderate glucose abnormalities, having a change from everything from the standpoint of a normal glucose function to abnormal or mildly abnormal, and then back again. So I'm going to summarize it up real quick. Basically, in these preliminary analysis of the 12 to 18 months of clinically prescribed ETI, we saw, although we saw a lack of improvement in oral glucose tolerance-related glucose excursion, despite a more appropriately timed insulin secretion, we think this needs more investigation. And whether this has an impact with changes in things like BMI, changes in lung function, whatever, just a prolonged investigation into it. The combined reduction in fasting glucose and hemoglobin A1C are suggestive of additional improvements with prolonged therapy. Increased C-peptide concentrations reflect increased insulin secretion. And the impact of ETI on insulin secretion and glucose tolerance require that prolonged study that I was just talking about. Because when we looked back at the data with ivacaftor and the changes in incidence, those took 4 to 5 years to really see those kind of changes. So maybe we're just not seeing it yet. And so that's what we want to continue to study. And with that, I'm just going to acknowledge the CF Foundation for both the funding of PROMISE Endocrine Sub-Study, as well as our grant funding through NIH at both centers, and the University of Pennsylvania Diabetes Research Center. And I'll take questions.
Thank you, Dr. Stalvi. I have a question from myself, and then we will also read the questions from the audience. Now, if you try to give a qualitative judgment on the improvements on glucose tolerance, insulin secretion, how would you rate them? Encouraging, striking, definitive?
I think it's encouraging. I think that I'm going to go out on a limb here and say that the future of CFRD research is not going to be probably overwhelmed by modulator therapy in adults. I think that the impact in young kids is where we need to focus, because the possibility of preventing disease before it occurs is the way we should aim. And I mean, I may be saying that as a bias since I am one of the investigators for BEGIN, but it's still, I think that's where the future holds us.
Okay.
So there's a question from the app. So moving on to the questions from the app, with the improvement in glucose tolerance with ETI, will we be able to raise the age of OGTT? If yes, what age?
That's a good question, and I know that the screening modality in CFRD is being challenged right now, and they've been kind of waiting on some of this data to look at from the standpoint of going forward with a mission statement and how we should screen, you know, whether or not we should still be using glucose tolerance tests, or should we look at other things such as continuous glucose monitors kind of stuff. I don't think it's going to change the age group per se, in that it's still going to be in the second decade of life, and the impact of diabetes in these individuals is still pretty overwhelming. So I don't per se think it's going to increase the age that we look at screening, but definitely I foresee a change in how we screen going forward.
Well, now there are two questions that are interesting because the first one relates to the age at study. And specifically, it's asked whether the ones with the largest improvements were also the youngest one. And this is possibly it's important because maybe the defects are arising earlier than we have, as we start the ETI therapy. And the second one, if you took into account also weight changes.
So changes in weight are a big deal. And we're seeing that, like I point out frequently, although I'm a pediatric endocrinologist, I work through the adult center at UAB. And the two most recent patients I've seen were clearly new onset type 2 diabetes. And they're individuals who were diagnosed later in life with CF, and it's straight up type 2. So the issue and the impact of the weight gain that we're seeing with Trikafta is weighing on this. And we don't have the information yet to really fully ferret that out. No pun intended for the ferret. But we don't have the information yet to really ferret that out.
Another very important aspect, what about insulin resistance?
Well, that's exactly where I'm going with this. And so how does that play into it? How do we use insulin sensitizers in this patient population where for so long we've been told not to use or shy away from? Yet there is clear evidence, well, I say clear evidence, it's anecdotal evidence, but still we're seeing it in the patient population where it's a insulin resistance type picture as opposed to insulin deficiency.
And did you make an analysis about the relationship between BMI change and insulin resistance change?
We have not done that yet. Like I said, there was an improvement in BMI Z scores, which I didn't show because that's been previously shown, but kind of detailing that out and how the changes in C-peptide and whatnot could definitely be impacted by that.
Any reductions in basal insulin doses?
I don't think so. The question was, and I'm going to turn to Andy to see if she can answer. Was there any reduction in basal insulin doses? I don't remember. As far as I know, there wasn't. Yeah.
There were some patients who had insulin intensification, and that's why they really wanted to not include the continuous movement into glucose substance that are insulin to worry that clinical therapy impacted some of those drugs.
Okay, thank you.
You have to remember that most of the patients that would be included in this kind of study that were on basal insulin are typically on very small doses. You know, they're on typically not more than about 5 to 10 units a day, just to kind of it's more supplementive, you know, to help from not only an anabolic standpoint, but also just to smooth things out, as many of us in endocrine deal with. So, you know, to make a change oftentimes with that dose of insulin, it's not, I mean, the body doesn't need it.
Right.
Yeah.
Okay, I think that is it for all the questions we have for Dr. Stalvey.
Thank you.
So our next speaker today is Dr. Bibi Nielsen. Dr. Nielsen is currently a PhD candidate at Copenhagen University Hospital, where she's investigating the pathogenesis of cystic fibrosis-related diabetes. Welcome.
So, start. Just start?
Yeah.
Where? Ah. Yes, hey, my name is Bibi, and as just said, I'm a PhD student and a medical doctor at the Copenhagen CF Center in Denmark. And today I would like to present this study called Decline in HB1AC during the first year on elexacaftor, tezacaftor, ivacaftor in the Danish CF cohort. And I have nothing to disclose. So as we just heard, we know that CFRD is a very common problem in our population, as more than 20% of our entire population, at least in Denmark, is affected by CFRD. With the increasing life expectancy, it's likely that the vascular complication of CFRD will become more prevalent unless the new triple therapy or ETI will reduce or improve the glucose intolerance in CF. So previous studies have suggested that ETI might improve insulin secretion, but it's also likely that ETI will reduce systemic inflammation. And by improving systemic inflammation, this can reduce insulin resistance, and it can thereby lower the glucose levels, and in this way lower glycosylation of different proteins, including hemoglobin, which we measure with HbA1c. And consistently with this theories, a previous study by Scully and co-authors by using continuous glucose monitoring, they have shown that ETI might reduce the time with elevated blood glucose levels. In the figure, you see that ETI reduced time above 140 milligram per deciliter by 10% after 7 months of treatment. So therefore, we speculate that this could also reduce the HbA1c. And we had these aims for the study to assess the effect of ETI on HbA1c in adolescents and adults with CF, both with and without CFRD in Denmark. We also wanted to investigate the effect of ETI on continuous glucose monitoring parameters and insulin use in CFRD. And the research questions were addressed in a Danish longitudinal study, which used blood samples from a database and which used medical records based on routine consultations in relation to the initiation of ETI. In Denmark, all CF patients are followed at either of 2 CF centers, which you are able to see on the map if you can localize the small country called Denmark. And then in Denmark, ETI was started in the fall of 2020, and all eligible patients were started on treatment for free. And in the study, we also decided to include the same patients who were treated with ETI. So all treated patients with ETI above 12 years were included in this study. And then measurements of HbA1c was scheduled at different time points. The scheduled time points for A1c was prior to ETI and 3, 6, 9, and 12 months after initiation of ETI. And then in a small subset with CFRD, we asked about their insulin use prior to ETI and 12 months after initiation of ETI. And in the same subset with CFRD, we asked them to upload their CGM data, if they had a CGM, to the hospital platform. And this is the baseline table, which shows almost 300 patients. And what I wanted you to take away from this is that generally their BMI was normal, and the vast majority were pancreas insufficient, and it was very rare to have anemia. And here is some of the results. We showed that in all participants, the mean change in A1C was 1.7 millimole per mole, or what you would say is around 0.1% after 3 months of treatment. And after 6 more months, the decline had reached 2.5 millimole per mole, which corresponds to 0.2%. Between age groups, there were no difference in the decline of A1C, though I feel that there was a tendency towards increasing age having a higher decline in A1C, but it was not significant. You can also see that there was a decline in A1C in both male and females. And so here we grouped our patients into different glucose tolerance status. And as you can see, there was a significant decline in A1C in all groups. Also here, it seemed that those with CFRD had a higher decline in A1C, but this was not significant. And the figure to the left is showing the same data as the figure to the right, or the table is showing the same as the figure. We also stratified our patients by prior modulator treatment. And we saw the exact same effect in the 2 groups. And this also made me think that genotype does not really cause any difference in the effect of ETI, since those who were on prior modulator treatment in Denmark were mainly homozygous for delta F508, whereas those who were not on prior treatment did only have 1 allele responsive to ETI. And so here's the subset with CFRD that we enrolled, and they were among the 26 patients, A1C declined in this small subset. However, we did not see a change in insulin use, though there was a tendency towards using less short-acting insulin, with the mean change being around 4.3 units per day after 12 months. And in the same subset using CGM, we showed that the glucose did not change over time. There were not even a tendency towards glucose declining on the CGM. And our patients told us that it was difficult for them to control their blood sugar after starting ETI, so we thought there might be a change in time out of range, but we could neither detect a change in time out of range. So the main findings in this study was that A1C declined in all subgroups during the first year on ETI treatment. Insulin use and continuous glucose monitoring parameters were unchanged in a subset with CFRD. And so this study does not explain why did we see a change in A1C. And I just have to come up with some different theories, which are very speculative, and I hope you can bear with me. First of all, reduced turnover of red blood cells might increase A1C, and this hypothesis is based on that previous study in untreated CF patients showed a higher turnover of red blood cells. If this would be normalized, then we would expect an increase in A1C, as we say that the high turnover is related to a lower A1C. Moreover, BMI would be likely to increase A1C if it's increasing the insulin resistance. And also, hemoglobin is positively associated with the HbA1c, and therefore an increase in hemoglobin would also increase A1C. On the other hand, ETI might reduce systemic inflammation and thereby improve insulin sensitivity, and this would reduce A1C. However, this would be through the pathway of reducing glucose levels, and we did not see a lower level of glucose, at least not in our subset. And the same is true for increased muscle mass and physical activity. If ETI would reduce muscle mass and physical activity, we would speculate that this would also reduce glucose levels, which we did still not see in our data. And then there is the final point that improvement in iron deficiency might be able to reduce A1C. However, it was so rare to see anemia in this cohort, so it doesn't really seem like a good explanation to explain that everybody declined in A1C. However, I have another theory that I would like to present to you. It has been shown that A1C is positively associated with inflammation, and this could be due to that inflammation will increase ferritin and the red blood cell size, which you measure with RDW, and this can cause higher HbA1c. If ETI reduces inflammation, it might also reduce ferritin and RDW, and it could thereby lower the A1C. Still, we did not measure ferritin and RDW, so we can only speculate about this, and further studies are definitely needed to confirm this hypothesis. So you will also ask now, is this even clinically relevant? And I don't know. But I'd like to say that A1C can cause endothelial damage by oxidative stress. Therefore, a change in A1C at 2.7 millimole could cause less stress in the endothelial, and this could potentially postpone the onset of CFRD complications. Still, further studies are needed. And finally, I just want to conclude what we saw. We saw that A1C declined by 2.5 millimole per mole after ETI initiation. Glucose levels were unchanged in individuals with CFRD. Less inflammation might explain the lower A1C, and lower A1C might delay CFRD complications. And finally, I'd just like to thank everybody who has been supporting me throughout this process. They seem to be sitting all in the front, but it's very nice for your help. Do you have any questions?
I'm just curious to know, are you planning to look into any of the inflammatory markers in the blood samples that you have for these patients?
It's not planned. I guess some of the theory about all the lower inflammation degree came after we saw that there were no change in insulin secretion, and and no change in glucose levels, though we will look at the neutrophils and the different cell types in the immune system on an overall scale, because we do not have TNF-alpha in these kind of cytokines measured, but we have this different immune cells. And CRP, yeah.
So there are questions about the possible effect on fasting glucose, and I would ask also if you have the data on insulin resistance. It's interesting to compare your finding with the PROMISE study, if you see differences and similarities.
I definitely saw the lower fasting glucose level, and I thought this was a very interesting finding. I would think that that would also have caused the lower glucose level in our cohort, in our subset. But I admit that clearly if we look, and we will look in OGTTs before and after ETI as well, and it can be a good explanation if the glucose levels is systematically reduced in all groups, that the fasting glucose is less, then it might also explain the lower A1C. And it seems that when you look at the fasting glucose, it should be related to the hepatic insulin resistance. So I think it's very, it's going to be very interesting to look at the HOMA-ER, which I guess is probably the best measure of hepatic insulin sensitivity or resistance that we have in CF at the moment.
And if I can add, is here anyone who measured systematically changes in waist circumference that may be also related to hepatic insulin resistance?
We have some body composition scans, not in all these patients, clearly, since this is 300 patients, and we will be able to see how did it change. And it would be very interesting also to compare that to the changes in OGTT.
There are questions regarding the methodology of continuous glucose monitoring and how many days were included for each subject in the analysis.
We used 30 days, and I didn't mention that, but it was 30 days to get not just a 2-day variation, but a broader variation. Yeah, get a bigger picture and remove some of the noise that you see from day to day.
And also, what was the criteria to select data collection dates for continuous glucose monitoring? If it is not too much specific question, if you remember.
Yeah, you mean what's above range and below range? I mean, we were asking them when we did the 12 months follow-up in insulin use, we were asking them to upload their data. And you say that sometime they don't use their CGM.
Like the most recent 30 days?
It was the last 30 days because it was on that day of the consultation that we would like, can you please upload the last 30 days? Yeah. I hope that answers your questions.
Again, did you make a specific analysis according on changes in glucose tolerance and according to weight change and glucose tolerance parameters?
Yeah, so the glucose tolerances that we have conducted, we haven't seen the hormones or the glucose levels yet. So we haven't been able to but you mean the glucose tolerance that are in this study?
Yes.
Yeah. No, it was the glucose tolerance was like the most recent all glucose tolerance that they had, and this was done on a finger prick. or what you
Okay.
say.
Okay. And
so
for continuous glucose monitoring and weight changes?
if no, we didn't look at the change in BMI and changes in CGM glucose levels. Yeah, it's just a small subset, so that's why I felt like it was not. It was hard to do very big analysis on this, but
Yes,
yeah.
a lot to do.
I don't think we have any other questions.
Okay.
Okay. Thank you.
Thank you very much. I think those are very interesting presentation and fresh data. Now, the next presentation is given by Dr. Saba Sheikh, who is a pediatric pulmonologist at the Children's Hospital of Philadelphia, with research expertise in clinical studies of cystic fibrosis and CFRD. Her presentation is entitled Preservation of Body Composition in Adolescents and Young Adults with Cystic Fibrosis. Dr. Sheikh.
All right. Good afternoon, everybody. I'd like to thank the chairs for inviting me to talk and the rest of you for still being here after 4 o'clock on a nice day here in Philadelphia. I'm going to talk about the preservation of body composition in a group of adolescents and young adults with cystic fibrosis. Let me see. Enter. Oh, that didn't work. There we go. All right, I have no relevant disclosures to this presentation. So most of you have seen the data that the CF Foundation puts out every year that looks at the association between BMI and FEV1% predicted in people with CF, and you notice this clear positive association where individuals who have a higher BMI have a better FEV1% predicted, and we've hypothesized before that this relationship is mediated through lean body mass, and in fact we've shown that individuals that association of lean body mass to FEV1% predicted is actually stronger than that for BMI. And traditionally, we've seen that individuals with CF who develop CF-related diabetes, or even those who have earlier glucose abnormalities, have declining BMI and lower FEV1% predicted. And therefore, we hypothesize that adolescents and young individuals with CF experience impaired lean body mass accrual, and there may be some association between worsening lean body mass accrual and your degree of glucose intolerance. And to this end, we did a longitudinal observational studies to assess changes in body composition in 26 CF participants without CF-related diabetes, and we followed them over a 2-year period at 3 time points, at baseline, at 1 year, and at 2 years. And we also matched them to healthy individuals. These individuals were matched by age, by sex, by self-reported race, BMI category, and we also roughly asked them their degree of day-to-day activity. And we did pretty well in terms of like follow-up, although we did have some loss to follow-up, and the COVID-19 pandemic certainly affected follow-up visits and loss to follow-up, and there's still some follow-up visits that are pending for those healthy controls. However, I think this is near completed data analysis. So we did DEXA scans for body composition assessment, and from the DEXA scans, we obtained lean body mass, the appendicular lean body mass, and the fat mass, and we converted these to indices. And for the individuals with CF, we also did the 75-gram oral glucose tolerance. You're all probably very familiar with this category with the categories of oral glucose tolerance. However, instead of using indeterminate, a lot of the data presented is for early glucose intolerance, where there's an isolated elevation of greater than 155 at the 1-hour glucose. And for our statistic analysis, we did mixed effects models to estimate the accrual of body composition indices among groups over time. And so your outcome variable here was really body composition, whether it's like lean body mass index, fat mass index. And we tried to see if over time there was a difference between the CF individuals and healthy individuals. And among the CF individuals, I was also interested in looking at whether their category of glucose tolerance or their OGTT glucose level was associated with differences in body mass accrual. All these models have been adjusted for sex and for age at the time of study entry. These are the baseline subject characteristics. I think we did a fairly good job with age matching. I've divided the data here by males and females. And so the average age was, the median age was about 21 for the males and closer to 18 for the females. And they're fairly close in terms of BMI. You'd notice that the median BMI for this group is a little on the higher side. In fact, a third of the participants were over 24. At baseline, what you will also notice is that the lean body mass index among males and females and cross disease status is similar. So there's no lean body mass deficits in these individuals, whether you look at total lean body mass or you look at the appendicular lean body mass. It's important to sort of lay out participation and that there was really no differences in the participation time among these individuals. It seems like the people who managed to do 2 visits or 3 visits, followed through, and then the pandemic didn't affect one group more than the other. And also, like when we do the analysis, we adjust for like these differences in participation. These are like the baseline characteristics for the individuals with CF. They're mostly pancreatic insufficiency. This is a relatively healthy group. Their FEV1% predicted is in the good range. At the start of this study, the majority of individuals were not on a CFTR modulator. And in terms of glucose tolerance, we have a fairly good spread, and as expected, because we didn't enroll diabetic individuals, there's none there. So these are the results. So when we plot their BMI over time, and here each plot or each line basically is a single individual. So these are individual subjects. I have the CF individuals in the top panels and the healthy controls at the bottom, and I've divided them by their sex. What you notice is that BMI essentially remains stable over time, and that their CF status was actually not associated with any longitudinal changes in BMI. This is your total lean body mass. These are similar graphs. The CF males and the CF females essentially over time were very comparable to the healthy control males and females. And overall, most individuals maintain their lean body mass. There's just very few, if you look at in the CF group, like maybe 2 individuals who had some loss of lean body mass. The story, again, is very similar for their appendicular lean body mass index. It's remained essentially stable over time, and there was no difference based on disease status. So then looking at the opposite end, like looking at fat mass, did they then instead accrue more fat mass? And again, if you're looking at these individuals, everything's fairly similar. There's no clear trajectory in one group versus the other. So when assessed over like a 2-year period, these adolescents and young adults with CF, they maintained their body mass and their composition, and this was very similar to healthy controls. Now within individuals with CF and across their glucose tolerance, I mean, these are just data over time, or the 3 time points, and essentially we had very little change in glucose tolerance over time in these people. There's 2 individuals who develop diabetes, one at their first-year visit, another one at their second-year visit. And if you were to look by their actual blood glucoses and the oral glucose tolerance, there's not a significant difference. And this just breaks up sort of helps you understand that there wasn't a great degree of changes in glucose tolerance. The majority of patients, like 15, remained unchanged out of the individuals that did worsen to develop CF-related diabetes, and the rest sort of just worsened a little bit. There may have been perturbations in their glucose tolerance during their first visit, because this is a comparison really of the first and the third visit. Now, these are the results by their glucose category. So on the left graph, we have lean body mass index. On the right graph, you have the appendicular lean body mass index. I have the colors of the graph the colors of the graph tell you the sex. So the only difference that you really see is we know that in the males have a higher lean body mass index compared to females, and that's why you see more males at the top end of the curve and more females on the bottom end of the curve. But if you were to look at whether you're looking at straight lines versus dashed lines versus dotted lines, there's really no pattern here. It doesn't appear that individuals who had worse glucose tolerance had lower lean body mass index, or were more likely to either lose lean body mass index over time or not accrue lean body mass over time. This is just that same data. Instead of categorizing the data by their glucose tolerance category, I'm just using their 1 hour and 2 hour glucose, and really it's the gray line that you can focus on, and basically it says that it's not significant. Neither the 1 hour nor the 2 hour glucose was associated with changes in their lean body mass index over time. So we also looked at fat mass over time, and again for these individuals, there's really based on there's no clear pattern based on their glucose tolerance category as to whether they were more likely to accrue fat mass or not. So we can say from this data that there's no significant differences in body composition with worsening glucose tolerance in people with CF, and I say that with caution because obviously this is a small group with not large fluctuations in their glucose tolerance. One more analysis for you guys to look at, and again limited by small numbers, and in trying to see whether CFTR modulator therapy played a role. As I mentioned earlier, or at least if you guys noticed on the first slide, most of these subjects finished their study visit somewhere around 2019, so I can't really talk about ETI here. But the majority of individuals at baseline were not on a CFTR modulator, and over the course of this study, many did go on to one of these categories of modulators. And so here, basically, this is just an analysis looking at, their lean body mass or their fat mass over time. So with CFTR modulator use or no CFTR modulator use, so whether you were on CFTR modulator at any point in the study or you were not on it. And essentially, if you just pay attention to the line in the grays, that's the interaction. Basically, there's no significant difference in their lean body mass or their fat mass over time. Again, in this small group of adolescents and young adults, we did not see any additional gains in lean mass on CFTR therapy. But again, as I mentioned, this is yes, no to CFTR, and there's no I'm unable to separate this out by which CFTR therapy you are on. So in conclusion, I think for this population of CF individuals, they are less likely to, they do not have lean body mass deficits that a lot of the data from the 1990s and the early 2000s had shown that there were a lot of deficits of lean body mass in individuals with CF. And so with advancements in CF care, I think that this data is sort of a reflection of the advancements in CF care, in that individuals are overall healthier. And also a small subgroup may be less vulnerable to nutritional decline with glucose intolerance. I'd like to acknowledge all the people who've helped me through this study, and then the CF Foundation and the NIH.
Thank you very much.
Questions?
Now the paper is open to discussion. I can start with a question. You correctly normalized your data on square height, but my question is, was the height, the score reduced in some of those patients, or was still height changing in adolescents, which really complicates the analysis?
So I think the height for the individuals were not different across groups. So they were actually like fairly like similar. I'm trying to remember I'm blanking on whether the height really changed across that group. A lot of these individuals were actually closer to like the 20 to 23 age group. And so they were beyond their, that peak height acceleration.
Okay. Any question?
All right, sweet.
Okay. So, is there any question still?
No.
What do you think that could be the role of insulin as a therapy for early glucose abnormalities when you have normal, healthy body composition data?
So in the past, there's been some data showing that if you treat individuals with early glucose intolerance, they have improvements in their BMI, and certainly the anabolic effect of insulin has been cited as a reason to start insulin early. However, in this subgroup, at least body mass or body composition is not a great rationale for using insulin. There may be other reasons, and I'm not an endocrinologist, such as like preservation of the beta cells and the stress on them, but certainly not their body composition being a good rationale for starting like insulin therapy.
Okay, thank you.
Thank you.
So it is my pleasure to introduce our next speaker, Dr. Remy Rabassa-Lauret. Dr. Lauret is Professor of Medicine and Nutrition at the University of Montreal. He is also the Vice President at Montreal Research Clinical Institute. His research focuses on the causes and consequences of cystic fibrosis-related diabetes, and he's currently leading the Canadian practice guidelines on this specific form of diabetes. Welcome.
Thank you very much, including for the French part of the presentation, my name and Institut de Recherche Clinique de Montréal. I'm impressed. As you know, CFRD can affect up to 50% of the patients living with CF. It is insidious. We need to screen it, and then the treatment is adding a very significant burden to the patient, though we hope that treating those patients will help them to maintain their weight and pulmonary health on the top of glucose control. So CFRD is obviously outside of that room a specific rare form of diabetes, and when I mean outside of that room, usually unknown. Screening, diagnosis, and treatment add significant burden to usual care. As patient partners tell me, we just hate the screening, and we hate when you speak about treatment. So roughly, I don't know anyone liking a disease, but this one is specifically hated by patients from the screening test. And research have raised multiple issues at each step. Do we still need OGTT? What are the thresholds we should use? what is the real usefulness of some treatments. So we decided to make a survey of how Canadian centers are doing in screening, diagnosis, and treatment. So we collected demographic data, some care organization, screening practice, how do the patients are followed and treated. So very simple what people are doing out there. We have close to 100 healthcare participants, and roughly, even if the numbers are not exactly there, you have 50, very close to 50-50 adult pediatric, very close to 50-50 respirologist, endocrinologist, and again, approximately 50% of MDs versus other healthcare professionals. So let's look to the results. The first and the most striking result for me is that only 1 patient of 5 have access to a specialist that do declare either an expertise in CFRD or some interest in CFRD, which for me is an absolute disaster. If those patients are seen as having diabetes, and by the way, they might have another strange disease with SCF, it's a completely wrong thing. They should see it as people living with CF, living with an additional complication, which is diabetes. Most patients are not followed within the respirology clinic, CF clinic. They are followed at another clinic, which means additional appointment and obviously additional burden. I will now present 2 or 3 slides with quite busy table, but I propose that you only focus on the overall numbers. So here are the screening practices. So in Canada, as in the US and some European countries, OGTT is recommended for everyone from the age of 10. So it's only less than half of the patient that actually had an OGTT as a screening measures. And obviously, the healthcare professionals are trying other ways. They are actually doing more self-blood glucose monitoring to diagnose CFRD. And I remind you that no association nowhere have acknowledged that you can diagnose diabetes based on capillary blood glucose. Same for continuous glucose monitoring. And there is an ongoing debate about the usefulness of A1C in actually a CF. So actually more people are diagnosed outside without an OGTT than with an OGTT. So roughly the guidelines are not followed. What about now if the patients have been identified with impaired glucose tolerance or impaired fasting glucose, which are 2 conditions that we know increase the risk of CFRD on the medium long term? So actually, how are those people done? Will they repeat OGTT? Roughly, it's only 1 patient on 2 in the adult population. A patient on 2 in the pediatric population, and 1 patient on 3 in the adult population. And again, a wide range of other tests like A1C, self-blood glucose monitoring, or continuous glucose monitoring are used. So again, OGTT is not used even in the most at risk or patients with known increased risk, not the most at risk. Now, how are they managed? The guidelines are very clear. Normally, the diagnosis of CFRD suggests that you should start insulin, not only to control for blood glucose, but to provide some additional help to maintain or increase weight and to provide eventually some additional benefit for pulmonary function. What happened is that a large part of the patient are treated with insulin, but a lot are treated with diet, lifestyle, and there is a lot of oral medications, specifically in adults. Our pediatric colleagues are probably far more compliant with the current guidelines. So not only a large part of the patients are with insulin, but another large fraction of patients are not on insulin, with a large fraction of them being on oral medications that usually for adult patients. So what we believe we found here, it's the first time we are really looking deeply in how we manage people with CF. And actually, that was the first step after patient partner meetings in our process to lead to new guidelines to exactly try to know what we are doing and what are the problems. The main finding is that only less than 25% of the patients with CF are really followed by someone who have some interest and expertise in CFRD, which is, in our opinion, a major problem. The key word for that presentation is that there is a huge heterogeneity in practice, whether you're looking for screening, diagnosis, and management. Everyone is making his own recipe at home, probably with some reasons of resources and frustration, but it's clear that homogeneity, we are very far from there, and we are far beyond what we need to individualize treatment. Pediatric colleagues are probably closer to the guidelines than adults are, and this is probably also reflecting general things, not only in the CF-related diabetes field. Few reflection about this. We believe that there is a lack of guideline knowledge, but this has not been measured in that survey. There might also be a lack of guideline applicability. We went back to some centers to asking for them. So, for example, in some milieu, organizing OGTT is very hard because OGTT has been taken off the regular list of tests that you can order, and the lab test responds, well, you can do an A1C. That's now a regular thing, and you can do a fasting blood glucose. Insulin therapy was also felt by a lot of centers as extremely hard to implement, follow, and manage. We clearly need, as Canadians, to improve our consistency. We believe that this goes through guidelines awareness, a training for endocrinology fellows around CFRD management. Usually this is beyond their training. They are not trained for this. Care organization, there was clearly a lot of centers without a clear pathway for that, one of the main complications of CF. And actually, we need also to try to simplify and get evidence-based management. I thank you for your attention, and I want to highlight that I'm speaking about a major group, and specifically Tamiza and Kirani, who was supposed to present today, but the baby came a bit earlier. The mom and the baby are fine, but so I am there to replace the mom and the baby.
So, thank you. And the paper is open to discussion. Are there any questions from the audience?
On our not so good performance. Not very proud of what we found.
No, instead.
Yes, there is one raised hand over there.
It's slightly related to your talk, but I'm wondering if you expect with modulator and weight gain, even though CF, or maybe the pediatric, if you expect to see more CFRD, then sort of force the training or the pipeline for more endocrinologists and focus on.
So the short answer is we don't know what is coming with CF modulators. The two first presentations suggest that we might slightly delay the onset of diabetes. My personal experience is that I've seen this all over the place. I was the one asking about weight gain in the first questions, the two first presentation. I've seen some patients with huge weight gain, and the clinical impression of an earlier onset of CFRD. I've seen others with less weight gain and reduced, for example, insulin dose. So for me, the jury is still out. And I believe that as CF people live longer, at least from the endocrinologist part, for the bone health, for the CFRD, we need to train our residents so they know a bit about this, and they understand that it's not someone with osteoporosis and a strange disease, or someone with diabetes and a strange disease, someone living with CF with some endocrine issues. I strongly believe with this, with a huge bias. That's a main interest for me.
Yes, thank you. Clearly, there will be a big change in the pattern of diabetes in future years, and we must be prepared. But for the moment, you have the chance now to tell us about the relationship between this investigation and the new Canadian guidelines. So
actually, the new guidelines are not finalized, but this was the first step of our guidelines, and we just want, the main objective of our guidelines is to bring a bit more homogeneous treatment and chance for the people to do this. The main change we will propose, I believe, is really to rely on A1C as the first step, and if it's really low, below 5.5, do not proceed to a GTT. It was really done with patient partners, and they didn't ask, they screamed for us to reduce the number of required OGTT. It was more than vocal. So we really looked to the literature to see what we could do for this, and there is now 4 papers in adult and pediatric patients living with CF, really showing that if A1C is below 5.5, the likelihood of diabetes is very, very, very low. So repeating A1C after a few months, there is unlikely chance that we would be bad for the patients. Again, at the other spectrum, at the end of the spectrum, if A1C is above 6.5, you can probably diagnose diabetes quite easily with another simpler test, like an opportunistic glucose, rather than taking the patient to the OGTT. Still, approximately 70% of the patient will still need an OGTT in our guidelines. And once again, it's not completely finalized and not endorsed neither by Diabetes Foundation or Diabetes Canada at this point, but they will go through a rigorous process of endorsement.
Okay, there is a final question. Other than training, are there other plans to disseminate the guidelines?
Yes, slides, website, conference, articles, all what we can. Good guidelines needs to be adopted and to be practical. I just got the feedback yesterday evening from the patient committee of the CF Foundation, and they had a very good point about how this can be applicable in the Canadian context. We are a larger country than Denmark, but we have our own problems.
Okay, thank you very much.
Thank you, merci.
Thank you. And we are to the last presentation that is given by Dr. Emily Godfrey. She is an associate professor at the University of Washington, and her clinical and research expertise is in reproductive health and chronic diseases. And the title of her presentation is Contraception and Pregnancy in a Cohort of Women with Cystic Fibrosis in the Era of Trikafta. Dr. Godfrey.
Okay, good afternoon, and just also want to say what a huge honor it is to be here today and to be presenting. And I'm going to say that this talk is the last talk of the last day of the conference, because, not just because NACFC saves the best for last, but this is actually a talk about sex, and I think it's no mistake that there's endless alcohol and a party soon to follow. All right, so talking about contraception in the era of Trikafta, which I will refer to as ETI from here on out. Let's see. So this is a study of a cohort of Case for CF. And so for some of you who are unaware, Case for CF is a CFF-funded nationwide study that stands for Assessment of Contraceptive Safety and Effectiveness for people living with cystic fibrosis. And before we dig into the details, I just want to thank my colleagues from the University of Washington who are listed here on this slide. And these are my disclosures. So we've kind of been hearing for the last several days that there is a growing number of people, individuals with CF, who are living into adulthood. And approximately 9,000 women with CF are now living into adulthood. And this is mostly due to the highly effective modulator therapies, or ETI. And I just want to make a note that when I refer to women in this talk, it's simply because research was reported that way, but I also want to be inclusive of gender diverse individuals who may be at risk of pregnancy. So prior research surveyed women with CF, and we found that their sexual activity is equivalent to women without CF here in the United States, and that women with CF use contraception at approximately half the rate as the general population. So when we know that highly effective modulator therapy came into the market in late 2019, in which 90% of the population qualified to take it, I think we know that the underlying defect that reduced fertility, meaning the thickened mucus and the hostile pH environment in the uterus, basically was corrected. And so I think it's no surprise that pregnancies increased based on prior data that we have about contraceptive use in this population. So this is a laundry list. It's released by the Centers for Disease Control and Prevention, which has national guidelines related to contraceptive use that are updated every 5 years. And you can see that this is a laundry list of complex diseases, and of course, cystic fibrosis is on that list. And the point is to say that cystic fibrosis, when a pregnant individual who is pregnant with cystic fibrosis is basically in a stressed state. And I think Raksha Jain reviewed the literature pretty well yesterday about pregnant persons being more likely to suffer from lung function decline. And when you compare pregnant individuals with CF to those without CF, the individuals with CF are more likely to develop gestational diabetes, pneumonia, suffer from preterm birth, and death. So the point here is that when a pregnancy is not necessarily planned or intended, the CDC is stressing the importance of contraceptive discussions with our patients. So the objective of this study was to explore past contraceptive use and pregnancy history among women with CF to better understand recent trends. So we disseminated a self-administered online survey study to women with CF aged 18 to 45. And for this particular cohort, even though this is a national study, we're only reporting findings from a single adult CF center in the Pacific Northwest. The questions on the survey included those about contraceptive use, pregnancy history, and CFTR modulator use going as far back as 2008. And of course, this was an IRB-approved study. So the question came up with, well, why are we using survey data when we have a CFF patient registry with so much information? And despite the wonders of the CFF patient registry, it does not collect information on contraceptive use. And so we thought about using the electronic medical chart, and the issues with the electronic medical chart, there was some prior research that I had done, not necessarily related to CF clinics specifically, but to primary care clinics that showed that what is in the EMR as it relates to contraception does not necessarily correlate with what people are actually using. And that partly has to do with a number of contraceptive methods are over the counter, and so those methods often don't get into the electronic medical chart. So certainly we sort of weighed the risk for misclassification, and we felt that if we can deliver a well-piloted survey, that we would reduce misclassification with a self-respondent survey versus the extraction of contraceptive methods from the electronic medical chart. So we underwent a piloting process. We surveyed 49 women aged 18 to 45, some with cystic fibrosis and others without. And this particular survey had 3 separate phases. And the point is that what we did was we looked at self-respondent solo responses versus self-respondent administered responses. And what we found through our 3-step piloting process was that indeed having pictures of contraceptive methods in the survey helped reduce missing data. It helped jog memory, basically, with use. What we also found was that our participants preferred to take the survey on their own, which would help recruitment efforts. But we did find that when a research assistant administers the survey, the responses are more complete. And so we had to compromise for our larger survey. So we surveyed approximately 600 women with cystic fibrosis, and we had to compromise by doing an administered survey with approximately 10% of our population to further understand the missing responses and to be able to impute missing responses in the solo self-respondent surveys. So this particular study is descriptive, and we're comparing our cohort to the general population here in the United States. For pregnancy outcomes, we looked at the Guttmacher Institute. The most recent data we have is 2017. And for the contraceptive ever use, meaning we asked women, what have you used at any one time in your lifetime? We used the National Survey of Family Growth, and the most recent data we have is 2011 to 2015. So in our particular cohort, there were 72 individuals with a pretty good breadth of age range from 20 to 44. Approximately half were married or cohabitating with their partner. The majority were white, and there was also a good breadth of educational levels from associate levels to graduate degree. Almost all were taking ETI, and 76% reported regular menstrual cycles. And then there was a smattering of people who were either sterile or their partners were sterile or were in a same-sex relationship such that they were not currently at risk of pregnancy. So with contraceptive history, so again, the question was, what have you used at any one time, at any time in your lifetime? So of course, there could have been multiple responses, but the point here is in the top row, you can see that every individual had used contraception at some point in their lifetime, meaning that contraception is a really important aspect for women and patients with CF. And the other thing to note, so you'll see that there's kind of a bright yellow and medium yellow and a lighter yellow. And so the bright yellow, the top two rows, are the most effective methods. And again, this is with guidance of the CDC. And those are permanent methods like sterilization, but also the long-acting reversible contraceptive methods such as the intrauterine device or IUD. And what's remarkable about the IUD is that we found that women with CF are using IUD 3 times greater rate than the general population. In terms of effective methods, and what makes them less effective than, for example, the IUDs, things like the pill and the patch, is that you have to take and remember to take a pill every day. So that's what makes it sort of less effective. And you can see that the findings are pretty similar to the general population. Where we find less use is in the 3-month Depo-Provera, which has been associated with reduced bone mineral density after 2 years of use. And of course, because of the inherent risk for lower bone mineral density in women with CF and persons with CF, it's not surprising that we see a lower use of Depo compared to the general population. And the less effective methods are generally what we consider the over-the-counter methods, or methods where you don't have to see a healthcare provider. And these methods are being used pretty widely by persons with CF and at similar rates as the general population. In terms of obstetric history, of the 72 individuals, 22 had reported that they had been pregnant at any given time, and 15 of the 22 individuals who had been pregnant had reported at least one unplanned pregnancy. The outcomes of 33 pregnancies from the 22 individuals, 42% had a live birth, which is notably less than what we see in the general population, where 60% end in live birth. And I think what's also remarkable is the findings that miscarriage was slightly higher than the general population. So miscarriage means a pregnancy loss prior to 20 weeks of pregnancy, and then 21% reporting abortion. This is simply just a figure to show that, of course, we know this, that CFTR modulator use has increased and precipitously increased in 2019 with the onset of highly effective modulator therapy. And then in terms of pregnancies per year, and again, this is going all the way back to 2008, but you can see that the top line, the dark blue line, is all pregnancies. And similar to what has been noted in the CFF patient registry of a marked increase after 20 2019, we also see that in our individual cohort. The orange line at the very bottom is assisted reproductive technology, or having medical help to get pregnant, which is what we saw in yesterday's seminar with the patients who were interviewed, the Smiths. But that essentially really hasn't changed over the last half decade. But what's remarkable is the gray line in the middle, and that represents the unplanned pregnancies, which is correlating with the increase in all pregnancies. So the point here is that pregnancies increased after ETI was introduced to the market at a single CF center, but we're also noting that unplanned pregnancy is common. We also noted that every participant had used contraception at some point in their lifetime, and the good news is that 3 times more individuals with CF are utilizing highly effective contraceptive methods like the IUD. But they're also still using less effective methods, and it may be because of the increased burden of seeing another provider, a women's health provider, or going to Planned Parenthood to get a prescription contraceptive method. So it really stresses the importance of contraception being addressed in the CF center. So indeed, there is a need for improved contraceptive counseling and management in CF. The other thing I just wanted to point out was the higher miscarriage rate that we noted compared to the general population. There's really, I think the only explanation at this point is we know pregnancy in and of itself is of greater risk to individuals with CF. And so there may be sort of underlying reasons, the inflammation, the increased inflammation, but the point is that I think we need to really start tracking and following the number of miscarriages that are occurring in this population. So of course we have limitations. Single CF center makes this less generalizable. In terms of next steps, we are analyzing the entire 10-center cohort, and we're also going to look at the risk of contraceptive failure with CFTR modulator use. And up here are the 10 different CF centers throughout the United States who are participating in this study. And I certainly want to extend a huge thank you to the co-investigators from these sites, as well as the participants who enrolled in our study from these sites. And just to end, to add my voice with other speakers in our conference this week about working against the harmful effects of legislative interference between healthcare providers and patients, and to take a stand for full spectrum reproductive health services, including abortion care and gender affirming care. All right.
Thank you very much. Are there any questions? Yeah.
So I'm just curious to know that the other CF centers that you will be working with, do they actually have a gynecologist embedded in their CF care team?
So that's a good question, and there have been some studies looking at kind of the implementation of gynecologists in other specialty clinics, transplant clinics actually. It's a hard model to sustain, partly because of the need for, revenue. And the problem is that patients, when they want an appointment, they want an appointment that works for them. They don't want an appointment like for the half day that the gynecologist is there. And so to my knowledge, there have been a number of CF center, or certainly high specialty centers, the transplant centers in California that tried it, but were not able to sustain that model due to revenue issues. Yeah, thank you for that plug.
Have any ideas about how we account for the much higher use percentages of IUDs
Yeah, so I'm going to just repeat the question in case others didn't hear it. And do I have any ideas for the much higher use of IUDs in the CF population? And this is actually a finding that we have found previously. So I don't think, again, I think it's a pretty accurate finding. Word has gotten out, I think, about the fact that previously, prior to the HEMT, fertility was reduced. I think that was kind of the language of the group, like, fertility is reduced and you're not that likely to get pregnant. But I think with modulators being introduced, and now with highly effective modulators, there really is now a need to, protect against pregnancy. And I think the family planning specialists have done a fairly good job of advertising the effectiveness of IUDs. And, for people who really don't want to be pregnant and recognize that there are higher risks than the general population to be pregnant, it is a desirable method. But again, these are patients who have access to care. The message, I think, is getting through, but I'm not sure that every patient really has adequate access to care to get these highly effective methods.
Thank you very much. And
you.
thank you to everybody to having attended such an interesting session. Thank you all to all the speakers. This has been a high-level session, excellent presentation. So again, thank you to everybody and see you next year. Thank you.